None of the content on this or any episode of the Kratom Science Podcast, Kratom Science Journal Club, or on any page of kratomscience.com is intended, nor should it be considered medical claims or medical advice. This is the Kratom Science Journal Club with Dr. Jonathan Cachet, neuroscientist and expert in psychopharmacology. In each episode, we discuss an article in a peer-reviewed journal. I'm your host, Brian Gallagher, blog and social media writer for KratomScience.com, your source for all things Kratom. So we got Understanding Kratom Use, a guide for healthcare providers. This was published in March 2022. This is a team of a few people that have been on the podcast. Marc Swogger led the study, spearheaded it. Kirsten Smith was just on one of the last episodes. Oliver Grunman was on. Henningfield has done a lot of research and stuff with the American Kratom Association. Albert Garcia Ramao, I'm trying to get him on. All these people have done pretty good research and some papers we have covered before. This is really good, I think. I mean, this is the one thing I was excited about in the last couple months that came out. Doctors can't know about every single thing, and not every doctor is going to be open-minded about, hey, I'm using this substance, we don't know much about it. They're not going to say, oh yeah, go ahead, if they don't know anything about it, and they might just Google it like everybody else does. I'm sure they would read a little bit more into it, but doctors are, especially, and when I say doctors, I mean physicians, especially after COVID, they're swamped, and if you come at them with like a new thing, they're going to look it up, and it's going to be case reports of liver toxicities and poison control center calls and stuff like that, and they're not going to necessarily delve into the science on this specific herb. So I think that's why this thing's pretty important.
I agree. I mean, so I think that this is probably the most important paper that we've pulled up and reviewed, this year, particularly because of what you were just saying. Like, it's directed at trying to provide, your doctor, your primary healthcare physician, your PCP, with a framework in which to understand Kratom. So it provides like a very up-to-date overview of the psychopharm, of the animal models, but then it also comes to best practices on how to deal with them. Of course, I see our good friend Mark up there as author number one, but I think this is very timely, and I'm happy that we're covering this one on the Kratom Science Podcast, because if there are any physicians out there that are listening, or patients who have already spilled the beans about their Kratom use to their doctor, this open source paper, providing that either doctor to patient or providing it directly to doctors is something that I think is definitely needed as we progress, especially on the use in that clinical setting. So very timely.
Yep, it's in Frontiers in Pharmacology. The full paper is available for free, and I'll have a link in the description. And if you feel comfortable showing this to your doctor, then by all means, maybe they'll read it. And because just the language in here, it's a lot of stuff that I wish we would see in other papers. They don't leave out possibility of adverse events, but it's not the headline, and it takes into account the majority experience versus the minority bad experience. So it's really good, and I think it would be great for healthcare providers.
No, so this is definitely, because it's a sort of article directed at doctors and primary care physicians, it certainly isn't incentivized by, like, let's say NIDA funding, where you have to either prove a benefit or toxicity. And so it's certainly not, like some of the headlines of the ones that we have read, you can just tell right off the bat that they're like, Kratom bad, and the sanity and the hysteria around it. This is definitely a very objective approach. I think it's written by like, you know, an interdiverse or interdisciplinary team of scientists, and everything is presented in an objective way too. So I agree with you on that, on that point.
I have a clip because I interviewed Kirsten Smith where she says why the purpose for the paper. So I'll just play that.
Marc was the one who spearheaded that, and he, Marc Swogger, and he and all of us, of course, first and foremost, want to have clinicians, if they are to go into Google Scholar or, you know, just Google Kratom, have some alternative other than WebMD or the Mayo Clinic. Beyond that, of just raising awareness, I think there's the hope that we have that, and again, I have a clinical background, so I was actually initially going to go provide substance use disorder treatment to people. That was what I thought I was going to do in life. And clearly things have changed quite a lot, but I am trained to assess people with a DSM-5 and diagnose people. And what I know to be true, both on the giving and receiving end of treatment, whether it's substance use disorder treatment, psychiatric health, physical health, a lot of the patient-provider dynamics are asymmetrical. So you have this person with a lot of knowledge and authority and quite frankly, a lot of power over you as a patient. And what really should be happening is this, what is called evidence-based practice or evidence-based medicine. And it's this process, right? And as part of that process, the physician or the clinician is supposed to not only look at the available evidence for any sort of intervention or therapy or treatment or clinical decision-making, but also to take into account the patient's preferences, values, desires, perspective, point of view. And so it's really, I think, challenging in America, which has a very difficult system to interact with anyway for healthcare, assuming you can get healthcare and treatment. It's hard even for patients who are very privileged and able or feel as though they're able to advocate for themselves and who feel empowered enough to maybe push back, not in a mean way, but just in a, you know, advocating for your own clinical needs. Because at the end of the day, you know your body and your health and your everyday life better than the doctor does on some level. Now, I'm not saying like, you know, how like a cancer is spreading, per se, but you know how you feel and you know more or less what you want your quality of life to look like. And that does need to be communicated to and received by the clinician. So we, at the end of the paper, wrote these tips for, you know, if you're a clinician, here's who might be more likely to be using Kratom, because we know a lot of the factors of like comorbidities or chronic pain or fatigue. I mean, all these different things. But even among healthy people, you know, who use it for recreation, that's also possible. But approach the person in a non-judgmental way, in a non-stigmatizing way. When you ask about Kratom use, include it as part of a standard assessment. Don't, you know, make it this special, unique thing, but do what you should be doing, I would say anyway, which is to ask about any sort of supplement, over-the-counter, herbal, illicit, licit, every, you know, the entire package. So it's not just Kratom, it's Kratom plus all the other things the person could be taking, and don't single it out as just this one thing, but do mention it, because your earlier point, I'm not sure if I were taking Kratom, whether I would tell my doctor about it for the reasons that your interlocutor said, but also I would want people to tell their clinic. It's this horrible feeling to have, because I would never say, oh, don't, you know, withhold information from a clinician. But at the same time, I mean, we talked about this on the show last time, and it's, again, not a secret. I have a history of IV heroin use, and literally just this past week, I wrote a piece from the perspective of a patient with a drug use history to physicians about how I would wish that they would interact with people like myself. And I am in a very decent position from having been trained to be where I am now, that I can interact with a healthcare provider in a fairly savvy way. But the average person is not equipped to exercise their autonomy and advocate for themselves in a way that I think might be needed. And so it is a very, 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 very unfortunate space to be in, where I wouldn't know. I don't think that we could recommend I'm specifically not recommending anything one way or another, because it's up to everyone individually on a case by case basis. Because if your doctor's like a really good human and really listens to you and wants to understand, then yes, I mean, why wouldn't you tell them? But once it's in your medical chart, it's in your medical chart. And that is a decision that every person has to make for themselves. But I would say if you're experiencing health problems, you should probably be as forthcoming as you can with your doctor.
Definitely. Okay, so that was it.
That was great. That was a great quote. And actually, I'm very glad that you played it, because my favorite part of the entire article, where they talk about patient trust. So the importance between the doctor and the patient relationship. And so they go into best practices for clinicians, and it starts with the assessment. And it highlights specifically the stance of a non-stigmatizing and respectful doctor may increase the likelihood of honest patient disclosure. And there certainly is, especially among chronic pain patients, this like concern, not only with kratom as an herbal medicine, but also with cannabis as an herbal medicine. Mm-hmm. It's a bummer, because you could end up losing your doctor, and having to switch doctors is, of course, a horrible place to be. And I think the way that the hospitals are being staffed and healthcare is being staffed is a whole nother issue. Like, I've had to switch my PCP 4 times in the last year, and it's just a complete mess. Maybe not for this podcast, but maybe. But like, it's hard to find a doctor that you can establish a trusting relationship with, where you are seeing them long term, and you can actually be, very forthright, honest, and open with them. And she refers to the evidence-based treatment process. And so the quote in here about patient-centered treatment: the evidence-based treatment process specifically highlights the need for clinical engagement and shared decision-making with patient values and the goals inherent in that process. Mm-hmm. And so even for me, and I guess they talk about the difficulties of a regular person to interact with their doctor, to talk with them on a real level about why kratom may work, or chronic pain patients. Even me, with a PhD in psychopharmacology, which I generally disclose like up front at the beginning so they understand where my level of knowledge is, I still can sometimes run into pushback to where, they're the doctor, what they know is canonical, written in stone, they know best, and they're not considering my input on where things may be. Or interactions or potential benefits or potential harms are. I know here in Ohio, like a lot of chronic pain patients, when the medical program came online, when they got the medical marijuana prescription, the physicians and physicians' offices just would sometimes cut them off just immediately. No gradual taper down or anything. They're just like, well, if you're using cannabis, then you can't be using opiates. And there is really no reason for it, no medical reason for it. And the worst part of it is, it's usually not the doctor who's making that decision. It's the administrative employees of the medical group that you're with. Like, they create policies that say no medical cannabis and opiates at the same time. And so even though the doctor may know that there is no risk and potential benefits in terms of like using less opiates because you have cannabis and they can potentiate the effects, or using your opiates in conjunction with kratom, or the in-between days, it's just unfortunate that they know that, but their hands are tied behind their back because of the way that some of these administrative clinics are working. But it's just so important. It's so important to have a doctor that you can be completely transparent with and open with. And it's unfortunate that, especially the way with how stigmatized chronic pain patients are, that it's super risky to bring these things up, because it could lead to the doctor saying, well, no, and if you're taking that, I'm not refilling your prescription, and I don't even know if I can see you anymore. Like, you have to go about finding another doctor, which is just, as a chronic pain patient, you're stigmatized at the beginning. Yeah. And they have to make some sort of evaluation of whether this is like drug seeking behavior or actually, something that is a medical problem that needs treatment. I'm sure there's tons of people that have had that experience
I had a guest on episode 70. I just looked it up. Sean Wenzel. She is a chronic pain patient. She has degenerative disc disease, and she got thrown off of pain medication because she tested positive for cannabis in Colorado too. So it was it was just one of those things like, what? And that's when she discovered Kratom. Up to 60% of patients turn to non-medical modalities for treatment. Healthcare practitioners must therefore be knowledgeable about the implications of using these substances. Going along with that, kind of a poo-pooing of everything as pseudoscience, even though there's a lot of science going on with Kratom, and there's kind of that, like, I'm using this herb that really helps me, because there is a lot of pseudoscientific stuff out there, so I understand it from that perspective. Initially, that might be the reaction, like, no, this isn't approved, and then starting with that prejudice, you look it up, and, DA doesn't recommend it.
It can be real difficult, like, it just says, you're saying, like, from just the base, the doctor is skeptical of any like homeopathic or herbal or any type of care like that. But up to 60% of patients are looking at these herbal and homeopathic and alternative methods. I didn't realize it was 60%. It's unfortunate that sometimes like even you have to consider your doctor as a person and their sort of ego when you're having these conversations, when that shouldn't really even be part of the conversation, or that shouldn't get in the way at all. Like if you are presenting valid sort of symptoms with valid sort of research that you have, for them to just dismiss it outright is unfortunate. And just like she said in the quote, and it's right under the quote, the best practices here that we're referring to in that first paragraph, when they do go to like drugs.com, when their first Google search for Kratom is news articles and these fear-mongering headlines, nobody has the time to read the articles anymore. I think we stopped reading articles in like 2000. Right now, everybody's titles only. So it's just articles like this, like she's saying, and the purpose of it was to get some objective information out there that hopefully is getting in the hands of the physicians.
Yeah, and I found the other quote was under the harm reduction section. Kratom has the advantage of being available to individuals who cannot access medical treatment due to barriers in the system or due to mistrust of the healthcare system, providing a potential self-treatment for OUD or anything else to a wide swath of people who would otherwise receive none. So, on the one hand, Kratom's not approved and everything, but on the other hand, people are using it because the same system that approves of drugs and gives out medical care is not accessible to them, or there's mistrust, probably based on how expensive it is. Probably isn't the only thing that sows mistrust, but it kind of gives you kind of like a justification for mistrust. Barriers to access.
Sure. Yeah, the barriers to access, especially in the United States, and COVID has certainly like put a rethought and a reconsideration across the board on a number of things. And what I hate to see, and this is an analogy, is I hate to see the worker blamed, but in this case, it would be I hate to see the patient blamed, right? So the general narrative, and that's being pushed is people's subconsciousness is nobody wants to work. The reality is nobody wants to work for nothing in a shitty environment with no purpose, right? Plenty of people want to work. They just don't want to work for minimum wage as a drone in a corporate, warehouse, and blaming it back on the workers like nobody wants to work anymore. It's like, no, that's not the case. No one wants to put up with shitty work anymore. And so you can't blame the patient in this scenario as well, just like you can't blame the workers. Like the system itself is excluding people from access, and even if they do gain access, like you're saying, the costs can get in the way. If you're on, like state-sponsored Medicare, Medicaid, and a medical cannabis patient, and, a chronic pain patient, like just switching providers, the insurance companies have just as much power as like the administrative units over these doctors, to where the patient can't be blamed for going to alternative methods when you have to do so much and there's so many costs and so much risk and so much change happening. in the medical program broadly. Like, gosh, I just wish it was better in the United States, but it's not. It's a bad situation for public health. I just don't see it getting better either. Access is a huge issue. And then losing access. Like once you say that you use Kratom, then you lose access. Like, how do you go about finding another physician in your area? Hey, they kicked me out because I'm a chronic pain patient. I've been using hydrocodone for the last 12 years. So I obviously have a dependence on it. So I wouldn't say it's an addiction, but I'm certainly dependent on it. And I need to continue that therapy. Can you take me in? And, again, these administrative units may say every doctor in this facility cannot prescribe controlled substances, especially opiates. So then you got to move on to the next one. A particular situation that I ran into was I was dealing with resident physicians. Are you aware of resident physicians?
So what's the story with that?
There's nurse practitioners and resident physicians that are like going through the training process. The nurse practitioner is pretty good on their own, but they don't have an MD, and usually they have to follow all administrative policies or consult with an MD. With the resident physician, that is technically your doctor. But then when it comes to writing prescriptions and actually like making recommendations on what the medical treatments or therapies should be, that physician has to go talk to an MD who is usually in charge of like 10 plus, 15 plus other MDs, because these hospital groups and associations are trying to save costs by like hiring students or resident physicians, much like universities don't hire tenure track professors anymore. They hire adjunct professors for a much lower cost.
Okay.
So it's just, there are definitely systematic barriers to access, and it's not getting any better. And that's why there's nothing wrong with switching doctors, and there's nothing wrong with switching doctors until you find one that you're comfortable with and that is comfortable with you. There are good doctors out there. There are doctors that understand, but gosh, my heart goes out to everybody who, gets put in that situation, because it can be really, a really high stress and high cost and sticky situation. And of course, as we all know, people go to the alternative treatments. If people don't know about Kratom, they probably know about heroin or, other potential street drugs. And, then fentanyl becomes an enormous worry, an enormous risk that, when I mentioned that I'm involved with the fentanyl project, just getting testing strips out to potential users, like it's such a bad medical decision for your doctor to put you into that situation. You know what I mean? Like it's the worst medical decision they could have made.
Another thing that screws with the healthcare is the sensationalized and negative reports. And I'll read what they say in this. Moreover, sensationalized and negative reports lead some patients to fear revealing Kratom use to their healthcare providers and misinform those providers about the risks of Kratom use. Recent publications in medical journals espouse Kratom use as highly problematic, and its effects contributes to the growing opioid crisis without adequate supporting data. This rhetoric can stigmatize users and mislead well-intentioned healthcare professionals into an anti-Kratom stance that could negatively impact their patients and patient-provider relationship. So
100%.
Yeah.
100%.
Oh, and I was going to say, like, they talk about, they use the term drug hysteria in this paper, which is, we hardly ever see that with some of these case reports and stuff, because the case reports themselves sometimes can fall into that classification. Unfortunately, warnings regarding Kratom exhibit features of drug hysteria, and it says, conclusions by many negative, sensationalized, or otherwise decontextualized media reports on Kratom have been questionably drawn from case studies and toxicology reports, which at best provide low levels of evidence due to unknown internal validity and generalizability and over-representation of extreme events.
Exactly. And once those core beliefs are set, like once that initial Google is set, your first, like, doctors have no time, so they're trying to browse through as quickly as they can. They get their initial impression, that's it, and it's not going to change. And it's not going to change really until probably a patient, I wouldn't say the administration, until they're forced to sort of reconsider it, right? Until they have to, until it's part of their, maybe they're doing continuing medical education, since we're just a headline only reading culture at this point, the drug hysteria continues, but that's again, why I'm glad, the group of people that pulled this paper together and we're promoting it on the podcast, because it at least is objective and not explicitly fear mongering, right?
Yeah.
So they do give a good overview of potential. They give potential side effects, potential drug interactions, and all interactions that, of course, we know and most people in this field know. But you want to be concerned about taking kratom with alcohol or with opiates or with benzos. And of course, like opiates plus benzos is the deadly cocktail. Like that's why we're losing people, that combination there. And they also talk specifically about like erythromycin inhibitors, PGP substrates. I thought it was cool that they specifically mentioned like those two things that could lead to clinically significant toxicity. I don't think I've come across that with erythromycin before.
Yeah, me neither. I pulled that one out. Are those like loperamide, protease inhibitors? Yeah, erythromycin. Are these all like anti-diarrheal drugs or something? That I did a quick Google, and that's PGP substrates. Calcium
is the one that's in like the anti-diarrheal tablets that you get. So it's an opiate that doesn't cross the blood-brain barrier. It stays within the body, so it can slow down the guts in your intestines, but you don't get the psychological effects because it can't cross that blood-brain barrier. So I guess that does make sense, because if you're taking an opiate for pain that is in your nervous systems, in the head, in the central nervous system, with another one that is you're putting additional slowing down that digestive system even more, and I can understand how that could be a potential problem. Just
compound that. They do also mention something we talked about, which is cytochrome P450 enzyme activities. So another drug that takes those same pathways, you're compounding it. And they also mentioned something else that is important, that it's particularly with higher levels of consumption where all this happens. So if less is more, if you use less, there's less risks of this stuff happening. But it'd be great if you could talk to your doctor about it, and the doctor would understand how kratom works.
Well, speaking of that and how much you're taking, what did you think about the dose range that they were reporting in the dosage section? Did that jump out at all to you? It says approximately 5 grams of raw plant material are reported to exert stimulant effects and have been compared to caffeine. Doses between 5 and 15 grams are reported to lead to relaxation and the analgesic effects. And my personal reaction was, that's pretty high. I mean, 5 grams of raw plant would be 10 capsules if they're half-gram capsules. Then, of course, 15 would be 30 half-gram capsules. It seems to me, browsing the Kratom subreddits, most people do the toss and wash, which is just blows my mind. And I guess getting 5 grams down in like 1 or 2 toss and washes is possible.
Yeah.
I just thought it was high generally. And it was sort of weird because they say, although no dose range can be clinically recommended, patients can be informed that some average doses are approximately 2.5 grams. So it was half of the 5-gram raw plant that they reported just at the top of the paragraph. But like you said, and just like with cannabis, people starting off, go low, go slow, figure out what doses are right, and then also potentially prevent heading down a path to dependence.
Yeah, I thought that was a little high because I get relaxation on 4 grams. I had some a couple hours ago, and I definitely feel relaxed with the energy. It's not just the energy at 4 grams for me. I ought to try doing like 2 grams at one time, see what that does. I'm sure it would give me like a little lift and not much of the relaxation feeling. But
I generally, when I was using capsules, I generally, started with like 6. So that would have been 3 grams.
Yeah.
Or I would do like, I would eat 4, have a meal, and then put 2 on top of that. But I've never actually sat down and tried to take 30 of those capsules. Can you imagine that?
Oh my God.
the burp after that, like, oh golly,
you know,
burp is going to be something crazy.
You know what's funny is, like, yeah, my dose would be 8 capsules, but I take tea, so it's 2 teaspoons. It's so much less of a, feels less like a drug when you're doing 2 teaspoons of making a tea than 8 capsules, because my friend, I introduced her to Kratom. She loves it. But she's up to like 10 capsules a day or something like that, and her husband, who's also my friend, was like, oh man, she's taking that every day. She's taking like 10 capsules. I'm like, it's only 5 grams. It's not bad unless she's spending too much money for them. But she recently just quit. She's like, quit. And I'm like, yeah, you got to take tolerance breaks or whatever. And I was like, do you get any withdrawals? Because I think she's been doing it daily for a few months. And she's like, nah, nothing.
Not really. Yeah, with that plant based and that amount of use, yeah. You may feel, it's the psychological versus the physical for sure.
Yeah, but it just seems like it'd be another reason for somebody's physician to get involved, because then you have your doctor say, this is within the lower range or the moderate range, but don't do any more than that. And the person could tell their spouse that, don't worry.
I was just saying, the other thing with dosing that's interesting, at least, is that, or trying to come off of dosing, is like, let's say you are taking 30 capsules plus, so a big dose of plant material a day, and you've been doing it for the last 2 or 3 years, but you are realizing that, you're spending too much money on this and that you need to cut that back. It would be great to be able to go to your physician and let them know about this, have them help you. So, and they talk about that, like alternative clinical treatments for OUD, to get on Suboxone or methadone. For some people, that would be of great value to them to help them get off Kratom, like to exit ramp off Kratom. And if you're just sort of like dropping all of this on your doctor the day you decided to quit and say, I've been doing this for years, and it's just going to be more difficult for them to, I think, help and trust you in this, in what could be considered like a mildly emergency situation. So it's, rather than bring it up when you need help like immediately, especially if you're facing withdrawal symptoms, it would be so much better if they had an idea that you were using Kratom, or at least you had mentioned it before you go in there and ask them to help you. I could just see how that could backfire.
The thing you said about them having not a lot of time is, like, I just saw a new doctor about in February, and I was thinking about whether to tell him, and I had my medical cannabis card, and I noticed, like, he was in a hurry, and I'm like, I just don't even want to have a conversation right now, because there's just
don't want to risk it.
Yeah, I just don't. I might, like, if I get to know him a little better, I might bring that in, and I use so little Kratom and cannabis that it doesn't really, just notice he was rushed, and I just did not want to sit there and have a conversation about something he might have never heard of with him, but maybe hopefully in the future.
Yeah, certainly, right? Like, even if you do start engaging in that conversation, in his head, he's already thinking about the next patient. So it wouldn't have even been effective. I'm pretty sure when I was in California, I went to a pain management clinic, and it was like one of those offices that wasn't associated with a doctor group. Like, it was, not in a strip mall, but in like, a big retail center with a Kroger in the corner, but all they did was pain management. But like plastered on every wall and every sign was like drug tests every week, compliance, absolutely no cannabis, absolutely no Kratom. Like, it was posted on every wall. And I just thought, gosh, these guys are like really trying to force patients down a specific path rather than consider each patient individually. And who knows, maybe they were getting kickbacks for Suboxone or some other treatment. It's wild. I just heard about a friend of mine's, one of his family members got diagnosed with cancer. And so they presented the treatment options, and they recommended a specific drug. And the guy goes, okay, well, I hope you don't mind me asking, but why are you recommending that specific drug? Are you getting kickbacks from that drug manufacturer? And the doctor was honest enough to say yes. And that essentially he found out that the doctor group gets like $150,000 for every patient they sign up on this specific drug. And
Wow.
it's just like, what a conflict of interest. That's horrible.
I think it might have been Sarah Silverman. She was talking about, she went into a doctor's office. She saw like notepads with this certain drug on it. There was like everything bit like a neon Budweiser sign of this drug. And she went in. He's like, I'm going to prescribe you this drug. And she said, let me guess, it's X. And he was like, how'd you know? She's like, it's all, you got up the paraphernalia all over your office.
Yeah, it's sponsored everywhere, like a NASCAR event in here.
Suboxone is the one now that they prescribe. I've even heard it prescribed for pain, which is weird because it has naloxone in it. It talks about it in here. Partial opioid agonist buprenorphine carries a lower risk of lethal respiratory depression when used alone, but has been identified as contributing to overdose deaths when used in combination with benzodiazepines and other sedatives. And then it makes the point there's not been significant study to determine if kratom in combination with benzos and other sedative carries similar, greater, or lesser risks. But they go on to say lethal doses in some of the mouse studies, when I guess some of these LD50 studies, when they died, it wasn't causes related to respiratory depression. And then they point out that Mako study from 1972 where they gave a rat 807 milligrams per kilogram, which is insane, and there was no signs of toxicity. I think that was pure mitragynine. They said kratom in it, so I think that was a slight mistake. But
yeah, it's like the elephant study. There's a classic elephant study where they like gave an elephant so much LSD that's like unbelievable. Like I'm exaggerating, but like gallons of LSD, and then the elephant ended up dying, and who knows what he ended up dying from, whether or not it actually was the chemical or like
probably have a heart attack.
He was like floating. He's freaked out.
Yeah.
But that, that's just an old, just classic study that gets brought up in these situations where it's like, you can't, the title of it was LSD kills elephant, not 20 gallons of LSD killed the elephant. It's like, same thing, water kills child, but it was the child fell off the dock and drowned. It's not that water killed them. It's wild stuff. I'm going to tweet out this link to this article. And, of course, Brian will have the links in the description of the video. But I'm also going to make a post to the Reddit, the Kratom subreddit with this paper, and just let people know this is an opportunity to like how to discuss Kratom use with your doctor. It's a great resource, and kudos to everybody who pulled this together. It's a great and timely piece.
Yeah, definitely. And any news on the Cannabis Museum opening?
So we are pulling the specific items together that we wanted to put in there, and it was a big discussion because we have like different themes. So like bottles, and you learn a lot about how the bottles have changed and bottle making, and like some of the bottles that the cannabis were in were radioactive because uranium became a thing. There's also one specifically about like advertising and this and the other thing, but the board, and what I pitched to the board and what we ended up going with is like, when we want people to come in there, we want them to see the broad range of how much stuff is actually here. Like my first experience going into the warehouse and seeing the books, the posters, the prescriptions, all of these things, the breadth of stuff related to medical use of cannabis. So that's what we need to be the first exhibit to be. And so now that we know what the exhibit is, we are pulling that information together. I'm not sure if we're going to be open in April, but we're getting very close. And I know there's a lot of local interest as well. I was wearing a Cannabis Museum shirt the other day, and I had to go to the post office, and 2 or 3 people asked me when it was going to open. But I still have a reminder to keep everybody posted. And, I can't, once it's up and running, it'd be great to have you out for sure.
Cool. Definitely.
I would like to just say that the Fentanyl Project, so it's fentanylproject.org.
Yeah.
The website has been finished now.
Cool.
We're able to collect donations, and we are setting up chapters in different cities. So right now it's in Atlanta and Charleston, and we're looking to expand that. But what the Fentanyl Project does is buy fentanyl test strips, puts them in a kit with instructions. You get about 5 test strips per kit. That way people can take them home and use them like the next time. But the idea is we're sending people out to the bars and the festivals and the potential like locations where users actually are, and giving them the test strips, or even their friends who are like, oh, I'd like to take that. I'm going to give it to my friends. So just putting the ability for testing for fentanyl in the hands of the users is the goal of what fentanylproject.org is. And so that's all up and running. And if anybody would like to get involved with that or make a donation or anything to that matter, definitely just get in touch with us. We are new and, off the runway now, and are looking for more people to get involved.
Awesome. Yeah, and I go to a lot of shows up here. I go to a lot of punk rock shows, and even for people, I guess, who just buy cocaine or something, that maybe even especially them, not
That's
especially,
what I'm saying,
but
anything.
yeah, any
point,
powder.
any street drug, any street drug that's a powder, should be tested. It's wild that people are putting fentanyl in cocaine because it's a stimulant, right? It's like not even the right direction. And, a lot of people don't want to, with the test strip, you have to, get a sample and put it in a liquid and then let it run up. It's kind of like a COVID test. And I know there's been some pushback about like, well, I don't want to break up my pill, and then I won't be able to use it. And so in having those conversations and in our instructions, like you can put it into a container, do the test, and then if it comes back negative, you can still drink the water. So don't necessarily. Plus, by the way, we're trying to make sure that you don't overdose and die. So just keep that in mind. Check
out fentanylproject.org and check out Understanding Kratom, a guide for healthcare providers. The link is in the description. It's an excellent overview of Kratom for anybody really that wants to find out about it. And check out the Cannabis Museum in Athens, Ohio. Please like, subscribe, rate, review, comment, share. Music is Captain Big Wheel. The song is Moonrunner. Kratom Science Journal Club is written and produced by me, Brian Gallagher, for KratomScience.com. Take care.